Thank you, everyone. I'm very excited here. Before I really go to my real topic, I want to share my feeling with everyone today here. The ADA2 research is kind of brand new field. We didn't start with not long time ago. I heard so much today, and seems we are listening a same feeling. Every cell's doing a different way, but from the clinical side, we'll just get the phenotype, and then how to treat them, what different cells they are doing. For the basic side, we try to find what's the mechanism, but how to combine this together. That's my own major topic today. I'm going to use one example, one mechanism as an example to describe how can we link this basic research to the clinical research together. So my topic is ADA2 deficiency, attenuates M2 macrophage differentiation. So at this picture, I think everybody is very familiar. Absence of ADA2 can cause damage of the endothelial cells. Another phenotype is absence of ADA2 can change the macrophage differentiation imbalance. So why this imbalance is so important? Because the macrophage can divide to M1 and M2 phenotype. The M2 macrophage is playing a very important role of the inflammation resolution. And M1 macrophage is pro-inflammatory macrophage. So once this ADA2 is not there, the cells prefer to differentiate to M1 macrophages, not M2 macrophages. Then the patient could get more inflammation. And these defected M2 macrophages could cause a stroke in the brain. I remember one of the questions that just got the discussions. Some people ask, nobody really studied on the microglia, and very important to study that because we cannot get the cells. And we're trying to use the in vitro system to generate the disease model to study that. But right now, we only can use the a simple way to generate M2 macrophages, which macroglia are also one of the M2 macrophages. So what happened to these ADA2 monocytes? I want to briefly introduce 3 different subpopulations of human monocytes. One is called the classic. This is CD14 positive and 16 negative. And another one called the inflammatory subpopulation. This is CD14 high and the CD16 positive cells. And the third population is called the repairing monocytes, which is CD14 low and the CD16 high positive. So in DADA2 patients, they have increased CD14 high and the CD16 positive versus this repairing population. This ratio is increased, which indicates more pro-inflammatory monocyte subpopulation in these DADA2 patients. What happened to these pro-inflammatory monocytes? How they differentiate to different macrophages? And here I just want to tell you what I'm using for the M2 and M1 macrophage surface marker. The blue one we're using for detect M1 macrophages by FACS. And the yellow marker we're using for detect M2 macrophages. If we give the cells different cytokines to mimic the environment in vivo, for example, we give the cells MCSF for 7 days, try to differentiate cells to M0 macrophages. And another day, we give the LPS and interferon gamma to mimic the inflammatory cytokine environments, the cells differentiate to M1. If we give the cells different cytokines like IR4, the cells can differentiate to M2 macrophages. This picture is showing just from very limited primary macrophages data from DADA2 patients. Here you can see they have decreased M2 markers in the DADA2 patients by FACS. So this indicates this M2 macrophage get defected. We also found they have the increased pro-inflammatory cytokine gene expression in DADA2 M1 macrophages, which by GM-SF induction. So this confirms the cells not even have less M2 macrophage differentiation, they also play a very pro-inflammatory cytokine markers in the M1 macrophages. The cytokine array shown in the similar way. The left side is MCSF-induced M2 macrophages. You can see the red one is DADA2 patient cells. They have much lower M2 macrophage cytokines released. And the right panel is showing GM-SF-induced M1 macrophage in DADA2 has much higher pro-inflammatory cytokines released. And from this, we have faced a very big challenge is the limitation of patient primary cells. The patient, most of them are kids, and only can give us several males blood, and how can we get enough cells to work on that? And we also face the difficulty to determine the primary mechanism. We see the phenotype, but we don't know which one is primary, which one is secondary. And we also face the difficulty is the treatment effects. The patients get treatment by anti-TNF-alpha, and this treatment could affect the phenotype we saw from the primary cells. This gives us a motion. We have to generate one system can use for the in future study. Here, I can show the pattern you can see. We get healthy donors and the DADA2 patient skin biopsy, and culture the fibroblast, reprogram to iPS cells. And these IP cells has the potential to differentiate to a different cell lineage, including endothelial cells, smooth muscle cells, and immune cells. And our lab established this platform to differentiate to iPS to the myeloid cells. So these monocytes can further differentiate to different macrophage subtypes. Use this platform, we are able to study the DADA2 patient macrophage function. So what we found is, first we characterize these cells compared to the primary cells. They are very similar pattern. The surface markers are similar with the primary macrophages, and the function, the phagocytosis, also similar, and the cytokine release also very similar to the primary cells. This means we can use these cells as our in vitro model. What we found, the DADA2 patient has similar like the primary cells. They have less M2 macrophage markers expression, and but this one is consistent with another patient study. It's just different. It described is the ADA2 deficient patient. We also generate IPS from this patient. They have similar M2 macrophage differentiation defect. So we are asking what's the mechanism. So what we know now is ADA2 is deaminase, is adenosine deaminase. So we want to see if these cells, without this ADA2, they have accumulated of adenosine in the cell culture system. So left side is knockdown URAN37 cell system, and the right side is the ADA2 deficient patient system. In both sides, we can see the adenosines accumulate more in the patient and in knockdown cells. This is a graph. And these adenosine, what they're doing. If we give the cells, primary cells, ahead with the extracellular adenosine, they can inhibit M2 macrophage differentiation. But this phenotype can be rescued by recombinant ADA2. This means adenosine play a big role in the M2 macrophage differentiation, and ADA2 is inhibiting this. ADA2 is inhibiting the effect of adenosine. Without ADA2, this could be less M2 macrophage differentiate. To further study this, we generate a knockdown system. We did RNA-seq with ADA2 knockdown. We found the key central role of IL-10 pathway is downregulated in these cells. Related, they have more IP10 and the tissue factor, which can cause the endothelial damage. And also they have this M2 macrophage marker is downregulated, and the CSF1, which is MCSF receptor, also downregulated. We also did the Western blot with these knockdown cells. We found they have defect phosphorylation of PKC data and the P38. What this doing, they have less differentiation with these markers. So this is my hypothesis. I think I think this is we just want to say that this defect of the pathway can affect M2 macrophage, can further cause endothelin damage with this joke. So thank you, everyone.